Welcome back, clinical problem solvers, to a Friday. Do I have the day correct this time, Robbie? It's Friday, right?
You're never wrong, Professor. Even when you're wrong, you're not wrong.
I swear, if you have a friend like Robbie, really, you are wrong, but he'll never let you feel wrong. Let's put it that way. Good morning. We're very excited for today. We have a special guest, and before I give the microphone to our dear friend Jerome from Medical University of South Carolina, where Robbie and I visited Charleston, and it was very, very beautiful. We have Amo doing the teaching. Amo, how are you doing today?
I'm good, Professor. Thank you so much. How are you?
I am well. Make sure to make me sound smarter than Robbie when you do the teaching points. We also have Vinicius. Vinicius, how are you, my friend?
Hello, hi everybody. I'm fine. So I'm very excited to describe for today's. So let's have a great discussion.
We can't guarantee that, Vinicius, but we'll have a good time.
Okay.
Jerome, please unmute yourself. Tell us a few words about yourself. And yeah.
Absolutely. So my name is Jerome Dees. I am one of the newly crowned third year medical residents at MUSC. I will be pursuing hospital medicine after I do my chief year in academic year 2025 to 2026. And very excited for the opportunity to meet you all and do some learning.
Jerome, where do you hope to be at geographically when you start your hospital medicine career?
Yeah, so I will hopefully I'll be able to stay at MUSC. My wife and I are from here. We grew up here. We now have a young son who has met both of his grandparents and all of his extended family. So it'll be pretty hard to rip him away from that. So I think
what's his name?
His name is Mason.
Mason, awesome.
Yeah.
Well, thank you so much for joining us today. And without further ado, we won't ask Robbie to speak until it's time to discuss medicine. So Jerome, start the case.
All right. So I want to put you all back in the shoes of a newly crowned second year medicine resident who was on his night float rotation. And I got a call from the triage hospitalist, and he essentially said, I have a good patient for the teaching service. The chief concern was dyspnea. So he had shortness of breath and right-sided chest pain. And so I want to share the story of a 47-year-old male. He had no known past medical history, but was very forthcoming about not seeing a physician in greater than 10 years. He presented with a several-hour history of shortness of breath, right-sided chest pain, and diaphoresis that started earlier that morning. He reported that his symptoms started shortly after he landed from his 1-hour flight, interestingly. He told me that he travels twice per month to a satellite location as he works as a sales representative for one of the local communities, one of the local businesses in his community. And he said that he has done this consistently over the past 3 years. And I think I'll stop right there.
Oh my gosh, Jerome, I can sense and understand why very clearly that you have been elevated to have the honor of being a chief resident. The way you're telling the story is very riveting and very engaging. And I think that's telling of you, but also telling of how interesting this case is to see a gentleman who was previously healthy, presumably, be healthy enough to go on a flight. And remember, the context here is that flying is a stress test for the body. And the fact that this patient navigated that and navigates it frequently tells you that his cardiopulmonary health at baseline has to be robust enough to tolerate the challenges that being in air does. And so the development of shortness of breath and chest pain from somebody who is previously this healthy means that they must have deviated significantly from their baseline. So just how sick this person is very different than somebody with a chronic cardiopulmonary disease who gets shortness of breath, because moving from that baseline may not be distant. And the other thing that's alarming in this person is not just what they have relative to their baseline, but also how quickly they developed it. So both dimensions of how we acquire data, what is happening and over what period of time, are both alarming. The deviance from the baseline is extreme, and how quickly that happened is also equally extreme. And so that pushes the patient into a very, very alarming scenario. And quite simply, we can talk and reflect on how the landscape of chest pain and shortness of breath and how we approach that from a cognitive perspective. which I would love for Prof. Rez to enlighten us, because I think nobody teaches the fundamentals better than Prof. Rez. I can't shake the ER mentality that I have in me right now sitting in ED that this triggers. This triggers a very simple reflex, which is the following. This patient has chest pain. Are there any alarm signs? The answer is yes. We've articulated why. And if there are alarm signs, then I need to know the answer in the next hour. I have two sets of tools to tell me what the answer is: an EKG and a troponin to diagnose acute coronary syndrome. And if that doesn't do it, then I have a CT chest with contrast that diagnoses almost everything else I care about. And so this person, upon just this history, I would be inclined to get an EKG and troponin, and I would scrutinize them to a high degree. And if they confirm acute coronary syndrome, which is a separate conversation about how to do that, then the patient gets on a pathway for why this is happening. How do we diagnose it? How do we treat it? If the EKG and the troponin do not confirm acute coronary syndrome, this patient would be going straight to the CT scanner for looking for all sorts of things: aortic pathology, pulmonary artery pathology, so on and so forth. So that's the pathway that this person is on, agnostic to the other details they provided, including where the pain is, whatnot. This is just chest pain. Are there alarm features? Yes. ACS? Yes, no, no. CT chest with contrast. There are some other details here, including location, context, and I think those you can use cognitively to make progress. But I want to shed light on the approach to chest pain in the ER. If there are no red flags, take your time. If there are red flags, then the patient immediately gets an EKG and a troponin. If diagnostic, done. If non-diagnostic, a CT chest with contrast. It's really that simple in real life, and ultimately comes down to how do you get better at figuring out who has red flags or not. But I'll pass the mic to Prof. Rez to reflect on that and any other clues he's latched onto here.
Oh my gosh, we have to leave it at that because honestly, I have nothing to add. And one question I just may ask Jerome, for this chest pain, was it pleuritic in nature?
Yes, yes, it actually was. I was going to get to that in the review assistance, but yes, it was.
All right. Well, then I'm gonna shut my mouth and let you give us the review systems.
Yeah, absolutely. So the other brief portion of the HPI, 1 week prior, he said that he had bilateral thigh cramping that resolved without any intervention. He attributed this to the amount of steps that he takes at his job. He normally takes around 12 to 15,000 steps per day. He has a Fitbit. And he said that, I may not have been hydrating adequately. But on brief review of systems, on the pertinent review of systems, he said that he did have a headache that feels like his usual headache that resolved with over-the-counter medications. He did endorse pleuritic chest pain and a new non-productive cough. He did endorse some exertional dyspnea, but he did not endorse any exertional angina type symptoms. Review system that was negative. He denied any presyncope. There were no palpitations. There was no real dyspnea at rest. He was actually speaking in fragments and sentences, and he denied fever and chills. His other medical history, very, very briefly. He said that he doesn't have a primary care physician. He has not seen a doctor in greater than 10 to 15 years, he said. He had a urinary tract infection and a sexually transmitted infection that he could not remember what exactly it was, or he said that he got a short course of antibiotics. His surgical history, he only had a wisdom tooth extraction. He didn't take any prescribed medications. He only took over-the-counter vitamin, no supplements. He had no known drug allergies, but his mother told him that he had a bad reaction to penicillin, unclear if it was anaphylaxis or if it was just a small rash of some sort. It was unclear. His family history is notable for his mom passed away from ischemic heart disease, and she developed heart failure afterwards. And his father passed away of prostate cancer, and he had high blood pressure. Social history that was relevant. He smoked 2 cigarettes per day and a half pack per day since about age 17, but he was gradually trying to wean himself off of that. He had 1 beer per day in a social manner with family and friends, and he had 1 standard drink of liquor probably per week. And he denied any recreational or illicit drug use. And I'll stop right there.
Wow. Okay. So we got some juicy data here, and I'll share my thoughts and then ask Robbie to add to those thoughts. And also, I felt like Vinicius, I don't want to stress test keeping up with you, Jerome, but he did well. He did well. I think, you know, the reason I asked about whether the chest pain was pleuritic or not was not necessarily that it narrows the differential diagnosis, but it prompts me to consider a few possibilities, and it helps me localize the site of pathology. Robbie and I once presented a case to Zofia, who's now a palm attending, who I'm going to have dinner with Robbie on Saturday night at a very fancy Italian restaurant, which I don't really care about the restaurant. You know me, just give me Chipotle or Chick-fil-A and I'm happy. But she told us if someone can point to where the pleuritic chest pain is, there's likely going to be pathology on that side of the thorax. And if you think about pleuritic chest pain, it occurs when there's any movement of the lung. So not just coughing, but if I hiccup, if I cough and I have chest pain, that's considered pleuritic chest pain. It's basically movement of the lung that results in worsening of the chest pain. And you got to think about, I think about the P's when we talk about it, pleuritic chest pain, the P's, and those P's include pericarditis, pulmonary embolism, pneumothorax, and pleuritis. And if we think about this, right-sided pleuritic chest pain, so is there some kind of pleural parenchymal pathology on that right side? All of a sudden, I'm very interested in imaging. And it will be interesting when Robbie starts discussing, once we get the exam, whether he would go straight to the chest x-ray or the CT scan. The cramping in the legs is really interesting that the patient would volunteer that. And how can we incorporate it into the problem we're solving? At this point, Jerome, I'm not really going to put too much cognitive energy in it because I still have to rule out the PE. I still have to rule out the pericarditis, the ACS. So it's sort of information that my mind is tracking, knowing that when someone says they're having cramping, that could be a muscle cramp. It could be a twitch. It could be a tremor, a myoclonic jerk. So there's a DDX for that. And maybe it becomes relevant, but it just gives me enough information to check the electrolytes, check a CK, make sure we're not dealing with a multi-systemic process. And you might say, could we be dealing with more of an acute rather than hyperacute? Because Robbie mentioned the hyperacute causes you don't want to miss, ACS, PE, and dissection. But remember the analogy that Aaron Berkowitz used, and I love this, and Robbie has a really good figure on it. If I roll this pen, right, on my table, the disease is happening, and eventually the pen falls on the ground, and that's when the patient notices it. So they're noticing it hyperacutely, but it doesn't mean it's hyperacute. But because hyperacute processes are just much more life-threatening, you have to first rule those out before you land on more of a subacute process. So I would say what this additional information does for me is make me pause and be like, well, there's leg cramping. Am I dealing with something that is affecting 2 organ systems or more? And then the right pleuritic chest pain really makes me want to evaluate that right hemithorax with the attention to the P's, the PE, the pericarditis, the pneumothorax, and the pleuritis. Mike, to you, Robbie, to add anything to that discussion.
Oh, absolute poetry, Prof. I have nothing to add. Yeah, I think the 3 Ps are such a great and very simple way of remembering, I think, what the NOMIS stuff is. All right,
Yeah,
Jerome,
absolutely.
back to you.
Yeah. So my thought process was the same as I was on, night float. So you just want to make sure you keep the acute differentials in mind, and then, the subacute things could probably be addressed in the morning. So that was my thought process as well. So we'll move to the exam. As far as his vital signs, he was afebrile. His heart rate was 115, and it was regular on my exam. Blood pressure, he was hypertensive, 154/105. His respiratory rate was 22, and he was 92% on 2 liters of nasal cannula. Keep in mind, he has no baseline oxygen requirement. Generally, he was well appearing. He was in no acute distress. He was essentially sitting upright at 30 degrees. His head and neck exam was pretty much unremarkable. Cardiac exam, he was tachycardic, as I said, he was regular. There were no appreciable murmurs, but he did have some jugular venous distension while he was at 30 degrees. His pulmonary exam, he had normal work of breathing. There were no appreciable wheezing, but there was some basilar bronchi I could hear on the right side. There were no crackers or wails, but he was speaking in short fragmented sentences. After I got his initial history. His GI exam, his abdomen was soft, but he was mildly tender to palpation in all 4 quadrants, and there was some mild distension there. There was no appreciable organomegaly, no peritonitis or rebound. In his extremity exam, he was warm and well perfused. He did have 2+ pitting edema bilaterally to the knees. In his neurologic exam, he was non-focal. He could move all extremities symmetrically, and there was no limited range of motion.
Yeah, Jerome, this is amazing. I think, gosh, I will, no matter what the conclusion of this case is, I will just remember the quality of your delivery and how well you really understand the crux of this case and the way you're presenting it. And I think there's a theme that's emerging here, and I think it's a theme that's really worth exploring, which is that the patient has a pressure overload phenomenon. And the way we know that the patient has a pressure overload phenomenon and is in, of course, the JVD that you've described, the patient's jugular vein is distended. And I think when you see that the jugular vein is distended, of course, there's a lot of inter-provider variability. But I think there's a really important concept to try to dissect. Is the jugular venous distension a consequence of the patient being hypervolemic? Or is the patient having jugular venous distension because there's pressure overload? And so I think it's really, really important to try to understand this principle and to try to make progress based on it. So said simply, if you are, just imagine that you are distal to the jugular vein, and you know that the jugular vein is distended, and what you're trying to figure out is the distension that the jugular venous vein is experiencing as a result of too much water in the system or too much blood in the system, heart failure, or is it because there's a blockage in the way? And a great example would be that you have a large thrombus next to your central line, right distal to that jugular venous distension, completely occluding the JVD, the jugular venous flow that JVD will distend. But the problem there is an obstruction. Obstructions can be internal or external, and a great example of an internal obstruction is a pulmonary embolism, and a great example of an external obstruction is a pericardial effusion. Volume overload accounts for the vast majority of cases of jugular venous distension. However, in cases of acute jugular venous distension, pressure overload diseases predominate. So we talk about having to know what the time course is for everything that we see. If you tell me your patient's jugular venous distension developed suddenly, I will meet you with asking you where is their obstruction, either in the pulmonary artery or the pericardium. It is true that there are some conditions where patients can get very volume overloaded very quickly. However, almost all those conditions are associated with a rapid drop in the patient's blood pressure as a result of things going backwards and not going forwards. So here, on first glance, without any context, you can look at this exam and say, this patient has volume overload. They have 2+ pitting edema, and they have jugular venous distension. However, when that analysis is merged with the idea that this syndrome began abruptly, you then have to say, well, what's my DDX for volume overload? And that DDX is pressure overload. And so I worry most about this syndrome developing so abruptly that the patient has an obstruction somewhere. And based on the fact that that this patient is having a right-sided pleuritic chest pain, I worry the most that this exam represents either acute pulmonary hypertension from a pulmonary embolism or acute on chronic pulmonary hypertension. The question you may ask and say, well, wait, hold on, what about the edema? How can you reconcile that? And I think this is a rare scenario where you might have to really worry about the patient not having hydrostatic increases causing their, not having hydrostatic pressure being transmitted from the heart, but rather that the patient has a local hydrostatic problem, another obstruction in their legs. So that's a whole complex concept, but I'll try to simplify it from one direction. In a patient who has jugular venous distension and bilateral lower extremity edema, 90%, 95% will have one cause for both those things: congestive heart failure causing volume overload, stretching the jugular venous vein, stretching the lower extremity veins, vascular leak. In a patient who develops both these things fairly abruptly, your gaze should be directed to the more morbid hypothesis that they have a strategic block in all three of those places: distal to the jugular venous space in the form of a PE, and proximal to the edema in the form of extensive DVTs. So I think this is why we say time course is queen. If you told me this story was a week old or 2 weeks old, I would say this is hyperacute heart failure, query myocarditis, Takotsubo's ischemia, but I'm really, really worried about extensive thromboembolic disease because of the time course here. So yeah, that's where I would be at in real life. But I'm curious, Prof. Rez, thoughts, anything else that caught your eye, anything you want to layer upon that?
I honestly have never thought about applying tempo to the jugular venous pulse, but now I will. And it's beautiful how you use the history to apply the tempo at time point zero where it's not unfolding before your eyes. I think it's brilliant.
All right,
Drum,
shall
I
we
was
just-
really, really intrigued and very worried, frankly, about the patient. What happened next?
Yeah. Okay, so let's get into some lab data. So the CBC, his hemoglobin was 14.8. He had a mild leukocytosis to 13. His platelet count was 222. On his metabolic panel, I'll just give you the labs. Sodium was 135, potassium was 4.3, chloride was 95, bicarb was 24. Creatinine was 1.4. Keep in mind, we do not know what his baseline is, and his BUN was 52. His glucose was 173, and he had an anion gap of 16. On his hepatic function panel, his T-bili was normal. His AST and ALT were unremarkable. Alk phos was within normal limits. Total protein was 7.2, and his albumin was 1.4, notably. His magnesium was 1.8. His phos was 2.8. His calcium was 8.7. And because of his subacute, questionable hyperacute presentation, we got cardiac biomarkers. His BNP was 12.6, and his troponin was undetectable. His lactate was 2.5. And I can go into the imaging EKG if you want, or if you want to discuss the lab data, we can take a pause here.
Oh my gosh, can we discuss the lab data first? Dude, Jerome, this is crazy, man. Wow. And so what I'd love to do is just talk about the albumin and the BMP. And then Robbie, I would love for you to talk about the B Nancy peptide in the context of jugular venous distension and how you're reconciling that. But you know what's striking? First of all, let's just the most striking abnormality here is the albumin. Let's just be real, and we're going to discuss that. But I just want to briefly talk about the BMP because many of you are going to be taking care of patients who don't have a prior creatinine. So you have to ask the question, is it acute kidney injury or is it chronic kidney disease or is it acute on chronic? And it's very important to ask that question. Let me first say this, and it's a pearl. And I learned it from someone when I was in Baltimore. If you don't have a prior creatinine and it's elevated, just assume it's acute. That's simple. Assume it's acute until proven otherwise. This whole time on CP solvers, we've just been emphasizing how acute processes require acute recognition and attention. But then there's other clues you can use. And probably the most sensitive and maybe the most specific clue is imaging of the kidneys. If the kidneys are small, it's chronic kidney disease. There is a component of chronic kidney disease that the kidneys have atrophied. Other stuff that people will send is a PTH. Usually when you have CKD, the PTH is up because the floss is up and the calcium is low, which simulates parathyroid gland to secrete parathyroid hormone. So in this context, I'm just going to assume this is acute, and we'll go from there. But even though I'm assuming it's acute, I think it's a bystander, Jerome. I don't think it's the main, endpoint of where the pathology is. I think it's just pathology as a consequence of pathology elsewhere that we have to explore. And I got the nod from Jerome, so we're going to go elsewhere to the albumin. The albumin of 1.4. Boy, Robbie, I was doing a clinical unknown the other day, and one of your teaching points came to mind, which was, in EPIC, it just shows the lab as red or black, red being abnormal, black being normal, but it doesn't justify the degree of the abnormality. So here, this is severe hypoalbuminemia. And most often we don't even think about that, but here you got to think about it. And now all of a sudden you have severe hypoalbuminemia, you have pitting edema, you have hypertension. Does this patient have nephrotic syndrome? So we're going to need a spot protein to creatinine ratio. But I also know that in the context of AKI, it can be overestimating the degree of proteinuria because it's just more concentrated. So you probably will send a 24-hour urine protein as well. So that's one place you can lose a lot of albumin. And we also know in nephrotic syndrome, when the albumin is so low, it increases your risk of clotting. So could this patient have nephrotic syndrome? Then that was a subacute component, Robbie, and then the PE was the hyperacute component. Possible. So I have a lower threshold to actually CT image, and I don't care about the AKI. I really don't, because we're ruling out life-threatening processes. The other place you can lose albumin like this, to this degree, is if someone has a gastrointestinal losing enteropathy. That is a very complicated topic, but just that they're having GI symptoms, a lot of diarrhea, we're not getting that flavor here, so it's unlikely to be the case. The most common cause of hypoalbuminemia is when you have inflammation and it's a negative acute phase reactant. Here, the leukocytosis is suggesting some degree of inflammation, but then you apply the law of proportionality and you're like, wait a minute, I've seen so many people with inflammation. When has their albumin ever been less than 2? And then another common cause of low albumin is cirrhosis. But even in cirrhosis, we don't see it this low, and the patient doesn't have other stigmata of cirrhosis. But remember, the exam can be totally normal in cirrhosis, but the platelet count is normal. The bilirubin is not abnormal. So cirrhosis is not the key. And then finally, you can have a vascular leak phenomenon where albumin is leaking out of the vessel, and what leaves behind is a concentrated hemoglobin. And here I'm looking, the hemoglobin is 14.8, it's low albumin, there's edema. Could this be a vascular leak syndrome? But I'll leave it at that. And if we're going to go down that route of vascular leak, that's when you got to get Robbie involved, because I don't he's the person I've learned that term from. But I would love to layer on that, Robbie. How are you incorporating the BMP? And if you could also just talk about vascular leak in general, just a little bit, even if it's not relevant.
Yeah, I know, Prof. Rez, I think I was just so struck by how now you are so much wiser as to what the time course is. And I think it is impossible to get an albumin this low this quickly. The half-life of albumin is about 3 weeks. So this patient's been sick for a while. And so I definitely think that the acute component that we're dealing with here is either that the patient has been slowly walking to and ultimately fell off of it in the way that he presented so dramatically, or that he has an acute things superimposed on something chronic. And so I think the main thing that I took away from this aliquot is the journey towards the time course, and understanding what the time course is also involves many other variables beyond what the patient is saying to you, because their experience may be different than what is happening inside their body. And so for me, this case is I'm radically reformulating what is happening to this person, and now know that this has been going on for some time. And I think that influences a little bit our analysis of what the BNP is. And I think if you look at the BNP in isolation, it tells you that the patient is unlikely to be experiencing significant stretch of his atria. And that might be because his atria are not stretched at all, or it might be that the stretch process is very, very acute. And so I wouldn't use the BNP as an argument to exclude a pulmonary embolism in this case, because the acuity of that might be fast enough that the BNP is not responsive to it, or that the PE may not be significant enough to actually stretch his atria. The other two big reasons why a BNP may be misleading is in patients with a higher BMI who do have heart failure syndrome, as BNP is cleared by adipocytes. And so when those adipocytes are more plentiful than otherwise, the BNP is low. It's also helpful just to keep in your back pocket that the possibility that a patient with a pericardial effusion can have a low BNP. And the rationale for that is to remember that BNP is from atrial stretch. And in pericardial effusions, the atria are not stretched, they're compressed. And so most patients with pericardial disease causing a JVB distension will not have an atrial stretch. And it's important to think about both a pulmonary embolism because of the hypercoagulability of nephrotic syndrome, and also the fluid overload state that nephrotic syndrome can produce to result also in a pericardial effusion. So I think both those P's that Prof. Rez mentioned early on are still very much at play. So here, the BNP, to summarize, very compatible with an acute pulmonary embolism and very compatible with a pericardial effusion. And so I think it goes to show, I was giggling a little bit in the middle of that conversation because, we're Rez and I internists at heart, and you can talk and talk and talk and talk forever for 34 minutes. But ultimately, the ER-based approach of show me the EKG, show me the troponin, and then show me the CT scan is still the underlying core truth of this case that hasn't changed at all for me. And so I'm going to blab away to ultimately tell you this person, I think, like Prof. Rez said, needs a CT chest with contrast. But when Prof. Rez asks, you always meet him where he's at. And I think nephrotic syndrome is a great example of vascular leak. The idea being in nephrotic syndrome that specific blood vessels in the body are leaky, and they're the glomerular capillary vessels. So what's happening in nephrotic syndrome? The capillary vessels are supposed to not leak albumin into the kidney, and the wasting of that albumin causes consequences elsewhere. But the theme of vascular leak disorders are essentially when that leaking is happening everywhere in the body. And so all blood vessels can be leaky, not just the glomerular ones. So the way we're going to distinguish nephrotic syndrome from vascular leak is the UA. If the UA shows that the albumin is leaking into the kidney, we call it nephrotic syndrome. If the UA is negative and we're leaking albumin, we call it a vascular leak syndrome. And Vinny, our friend from Brazil, who presented a case of dengue about a week and a half ago on Sunday, showed us the best example of what vascular leak syndrome is with acute dengue hemorrhagic fever, which leaks fluid like no other, causing a low albumin and a high hemoglobin like we see here. But there are other hematological conditions that cause vascular leak. So to summarize, vascular leak is an entity where blood vessels leak albumin into the space that they're perfusing. If we have a focal vascular leak in the kidney, we call that nephrotic syndrome. If we have a diffuse systemic vascular leak syndrome, we call upon systemic diseases like dengue or hematological issues. So I think the UA is going to be the key test to tell us, is this nephrotic syndrome or is this systemic vascular?
Thank you so much, Robbie.
Oh yeah, for sure. Prof. Rez, anytime. All right,
That was
Jerome.
that was a very, very rich discussion. And just to give context to the next portion of information. So I was the admitting resident overnight, but our triage hospitalist kind of takes calls from all of the neighboring hospitals throughout the state of South Carolina. We're like the tertiary quaternary referral center. So the ED already had a chest x-ray and EKG by the time they called. So, they signed that information out to him, but this is what he told me over the phone. And then once I examined the patient, then it became a little bit more internal medicine and academic. So the chest x-ray showed no evidence of pneumothorax. There was a right middle lobe and right lower lobe infiltrate. There was no focal consolidation, and there was bilateral basal atelectasis. The EKG was sinus tachycardia. There was some non-specific T-wave abnormalities, but there were no overt ST changes, no ST elevations, no ST depressions in any of the precordial leads. But there was some evidence of left ventricular hypertrophy. And so I can, because whenever I got the call, the triage hospitals was like, this sounds like this could be a pneumonia with the subacute presentation, the new oxygen requirement, the non-productive cough. So he already ordered the respiratory viral panel, which was negative by the time I got there. Then once I came down to examine the patient, I said, okay, we need to get a CT chest with PE protocol. And I also added on a CT abdomen pelvis with contrast, just given his abdominal exam, the mild tenderness. He had bilateral pitting edema. And the CT chest with PE protocol showed a nearly occlusive right pulmonary artery thrombus, evolving right middle lobe infarct, and unremarkable lung parenchyma otherwise. The CT abdomen pelvis with contrast essentially showed a subtotal occlusion of the IVC, and there was a subtotal occlusion of the right renal vein thrombus, and the liver morphology was non-cirrhotic, but there was some evidence of some ascites. I have some other data that came a little bit later on, but ultimately, our discussion on the nephrotic syndrome will become relevant later, but I think we can probably take some time to talk about the imaging.
And Robbie, I know you're going to talk. Oh, are you presenting still, Jerome, or is it?
No, absolutely. That's a pause.
No, I know, Robbie, I do want you to, you had mentioned that you were just concerned for an obstruction lower based on the jugular venous distension and the acuity. Can you just, in addition to interpreting all the imaging, reiterate like what you taught us? Like, why were you so worried that there was something happening below the level of the heart?
Oh, Prof. Rez, I honestly would love to hear how you're putting this together. So maybe I can use this as an opportunity to just re-explain a complicated concept that we talked about on exam, and then maybe you can like analyze it and take it from there. Yeah, I'll take another crack at it because actually this is the first time I'll just be honest. VMR is, we learn more than all of you on VMR. And when Jerome presented that exam, a subconscious concept that I've seen in real life just became clear. So that was actually the first time I was trying to explain it to you all, and so I was gaining clarity on it in real life. I think that Prof. Rez, the ultimate facts we know when somebody has a JVD distension and lower extremity edema is that there is high pressure, venous pressure in the whole circuit, right? And so in most instances, we make the assumption that high pressure in the jugular venous vein and in the IVC and in the femoral veins is from the same lesion, often the left ventricle, most common cause of heart failure, right? So we say, oh, the legs are swollen, the neck is swollen, the lesion's probably in the heart, it's probably in the left ventricle. But in order to develop that kind of hydrostatic pressure that enough to transmit it all the way back into your legs, you need time. You need days, weeks, maybe even months. So the patients who we have seen who develop hyperacute heart failure, who have a massive MI, who develop cardiogenic shock from it, almost never have any edema. So when you see the rapid development of hydrostatic pressure, you're like, wait, hold on. This person wasn't swollen last week, and now this week is severely swollen. It calls into question whether the patient's lesion is truly a central one that is communicating all the way down into the heart, into the legs, and raises the possibility that the patient has multifocal occlusions in different places. And so I just think that acute hydrostatic pressure, you should probably prioritize thrombus over heart failure. And so the fact that he got so sick so quickly made it seem less likely that his ventricle was communicating all the way down until his toes, and raised the possibility that the reason his toes are swollen, even though his central process is so acute, is not because the central process made it all the way down there. It's probably because he has multiple different lesions in different places. I don't know if I'm making more progress on it, but maybe next year it'll be a little bit more clear.
It was very clear. Thank you. And I also love the point you made about the BNP and PE, which holds true in this case. two things like I really didn't know. Jerome, before I start speaking, I was just curious. We are leading towards nephrotic syndrome. I just want to confirm that before I start talking about it for a couple minutes.
Absolutely.
Okay, thank you. And the reason I wanted to confirm that is because so much of what we're seeing in this patient is really a consequence of nephrotic syndrome. So what is nephrotic syndrome? Robbie gave us a very good understanding of the leak at the level of the glomerulus. Well, where you have a lot of stuff that shouldn't be leaking out. Most specifically, albumin, which has a high molecular weight. And that's why for the diagnosis of nephrotic syndrome, there's the triad. You pee out protein, so you have nephrotic range proteinuria greater than 3.5. And as you're peeing out the albumin, your albumin becomes low. So you have hypoalbuminemia, less than 3.0. And you have lower extremity edema with the loss of oncotic pressure. Many times these patients have hypertension. And on top of that, they have hypertension because they just don't do good body fluid homeostasis and an increased load on the heart. The liver, in response to the loss of albumin, it starts synthesizing LDL and triglycerides and other lipoproteins. So you have hypertriglyceridemia. So those are the consequences of nephrotic syndrome. And by the way, you lose immunoglobulins. So can those infiltrates be pneumococcal pneumonia because that organism requires opsonization from the immunoglobulins? And oh, by the way, you lose antithrombin 3, protein C, protein S, and this leads to a hypercoagulable state. And here we're seeing extensive thromboses in the venous system. And additionally, if you think about it, the renal vein thrombus is very rare outside of two conditions, renal cell carcinoma and nephrotic syndrome. And the way I don't know if this is true, but the way I make sense of that is like if you have a cancer there, it's going to be focally more hypercoagulable than elsewhere. And if you're literally losing the clotting and anti-clotting factors right there in the level of the kidney, you're more at risk of a clot. And I want to just applaud Jerome because he really thought like an athlete would, a couple steps ahead. It would have been so easy just to get the CT of the chest, but he extended it to the abdomen pelvis, which I think gives us very useful information to the severity of what's happening. So Jerome, I'll conclude this by saying this nephrotic syndrome is leading to probably pulmonary infection and extensive venous thromboses. I would treat this patient for a community-acquired pneumonia, and I would start this patient on Lovenox therapy. I would choose Lovenox, and I would talk to the pharmacist and make sure it's okay with this patient's EGFR. It's just so much easier to administer than heparin. It acts so much quicker. I'm not yet ready to give this patient a DOAC, even though I haven't diagnosed him with intermediate risk PE. I'm just worried with these extensive clots. And one more thing, I know I'm going to have to likely biopsy the kidney. There's only one instance where you can diagnose the cause of nephrotic syndrome without a biopsy, and that is phospholipase A2 receptor antibody, a cause of primary membranous nephropathy leading to all other causes. You need a biopsy. And I personally feel the biopsy should drive the test, but oftentimes it happens simultaneously. So Jerome, please give us the next set of information, and then Robbie can layer on to the nephrotic syndrome discussion.
Yeah, absolutely. So overnight, once I got the radiologist called me before the read was even in and said, hey, he has an extensive clot burden in his, in the central system. And then there's what appears to be more clot that's almost in transit going to be like a PE. So he wanted me to mobilize our pulmonary embolism rapid response team. And so that's essentially what was the next move overnight was I had to get in touch with interventional radiology, our cardiology, our interventional cardiologist, as well as our pulmonary critical care colleagues, because he was going to go for emergent thrombectomy. So that essentially did happen. There was a successful thrombectomy. He went to the ICU for a short stay just to ensure hemodynamic stability, and then he came back out to the floor where the more extensive workup for the nephrotic syndrome essentially started. So overnight, my mission was accomplished to essentially alleviate his clot burden, but then we had to essentially work on the more subacute to chronic process that we figured out. So once we had all this data, the nephrotic syndrome became way more pertinent. We went to get more additional history from him. His BMI at the time of his presentation, he had a BMI of 38, but he said he has been gaining weight over the past 6 weeks, and he really didn't know. He said he went up in pant sizes. He couldn't fit in the airplane like he once could, a few months ago, because he travels twice a month. But the workup essentially showed his triglyceride levels were in the 300s. Because of his elevated protein gap, we got hepatitis C antibodies, which was negative. He had HIV antibodies that were negative. His Hep B core antibody ×2 was positive, but his surface antigen was negative. His spot urine protein and creatinine ratio was 4.7. His antithrombin 3 level was low at 70. His complement level, C3 and C4, were low. His factor V was within normal limits. Protein C and S were at the lower limit of normal. And his SPEP with IFE essentially showed that it was polyclonal eventually, and then we did a 24-hour protein collection that basically confirmed that nephrotic range proteinuria. And so we've already kind of outlined that discussion, but there's that's essentially how his case did progress. And if there's anything you want to discuss there, I can reveal the final diagnosis in the last aliquot.
Yeah, thank you so much, Jerome. This is very, very enlightening. And I think it goes to show you how we tend to work up nephrotic syndrome. As Prof. Les outlined, there's really 3 main histological types of nephrotic syndromes. There's membranous nephropathy, there's focal segmental glomerulosclerosis, and then finally there's minimal change disease. Those are the 3 histological types that get most attention, but there are 3 other histological variants that are worth keeping in your back pocket should those initial 3 not bear fruit. And that is membranoproliferative glomerulonephritis, which can actually bridge nephritic and nephrotic. There's IgA nephropathy, which can also cause a nephrotic syndrome. And then finally, the spectrum of amyloid-related kidney disease, which includes light chain amyloidosis that you just worked up, but also includes other form of amyloidosis. And so our attention is always on those first 3. And the question is, can we make progress with blood testing? And as Prof. Rez said, the answer is often not. The vast majority of patients with nephrotic syndrome have a disease restricted to the kidney. And that's what's called primary membranous, primary focal segmental sclerosis, or primary minimal change disease. The secondary workup to look for a systemic cause really takes a brief look at autoimmune diseases, namely lupus, and then chronic viral infections, which is the hepatitis A, hepatitis B, hepatitis C, and HIV. In a patient who has risk factors for sexually transmitted infections, you might also consider sending an RPR for syphilis, a rare but really important cause that Yusuf fooled us with a long, long time ago. And so I think that workup is essentially complete for this patient. And as Prof. Rez said, now that a secondary cause seems less likely, the primary categories of primary membranous, primary FSGS, and primary minimal change disease seem to be the most likely. Minimal change disease is relatively uncommon in adults. The tension often is it FSGS or minimal change disease? And that radically changes your treatment. Obesity is a very well described risk factor for focal segmental glomerulosclerosis. However, patients with FSGS tend not to have this degree of hypoalbuminemia, which is more correlative with membranous nephropathy. And so I think, as Prof. Rez said a long time ago, the serum PLA2R receptor antibody is the only way out of a kidney biopsy here. It has excellent sensitivity, specificity, and correlates with disease activity, so used as a biomarker to follow patients should they have this diagnosis. So that's where I'd be at, Prof. Rez. Anything to add before we hear from Jerome? All right, Jerome, the mic is yours, my friend. Tell us what you found and how you're putting it together.
Absolutely. So we actually reached out to our friendly neighborhood nephrologist, and they did send off the phospholipase A2 receptor antibody, and it was positive. he underwent a subsequent kidney biopsy that did show membranous nephropathy. And so they were essentially calling it membranous nephropathy with phospholipase A2 receptor body positivity, which leads to a progressive podocytopathy and leads to very profound albuminuria, which led to the his low oncotic pressure that kind of predisposed him to all the things that we've already outlined in our previous discussion. So and after that, he was on therapeutic Lovenox while he was an inpatient, just anticipating that if he did need another procedure or another, because he had other health problems that basically became evident throughout his hospital stay. But the nephrologist essentially wanted to treat him with 1 dose of rituximab while he was in the hospital. And then they were getting him established with like a neighborhood, somewhere in his community where he could go to an infusion center to kind of get rituximab through his nephrologist and oncologist out in the community. We had to find him a primary care physician to kind of help manage his hypertension and just make sure he had adequate follow-up. They started him on blood pressure medications, both losartan 100 milligrams daily, and he was eventually transitioned to apixaban on discharge. And then the infectious disease doctors, even though he had resolved hepatitis B, which we still don't quite know where that came from, they treated him with entecavir. And so that's ultimately how the case unfolded.
So, Jerome, that was probably one of my favorite VMRs, honestly. Like, I think from the start, like the dancing with Robbie and like just seeing how the case unfolded, so helpful. And like something I never thought about was just like that total protein being up, and like if you're losing everything in the kidney, why is the total protein up? And like oftentimes everything is down because you're losing protein indiscriminately. So there's something other than albumin that was up. So I thought that was really smart of you guys to do the SPAP and consider other etiologies. But I don't want to take time away from the one and only Amal, who has been typing aggressively. Would love to give the mic to her to take us home.
Thank you, Prof. Rez, for making my day. And thank you for the wonderful discussion. I learned a lot. So starting with the case, we had the chief complaint of shortness of breath and right-sided chest pain. So we thought that initially, if the patient comes with these complaints, we need to compare it with the baseline. In this patient, the baseline was normal. So the patient developed the symptoms with significant deviation from the baseline. Otherwise, there are patients who have chronic cardiovascular compromise, and then the DDX changes in both of them. The main complaint was of chest pain. We said that we need to look for alarm signs. And if the alarm signs they are present, we need to get an ECG and a troponin done, which can diagnose acute coronary syndrome for us. But if ECG and troponin, they are non-diagnostic, then we can go for CT chest with contrast to further evaluate the chest pain. Pleuritic character of the chest pain, it helps us in localizing the pathology. And we consider the P's, pericarditis, pulmonary embolism, pneumothorax, and pleuritis. Then we also had leg cramping, which could be as a result of a simple muscle cramp or a twitch. And then we thought that we have to get the electrolytes level done, a CK level done as well. And we thought that could it be a part of a multisystemic process? And then we had the jugular venous distension on the examination, which we realized that it could be due to 2 reasons. One, it could be due to hypervolemia, that is increased blood or water in the system. Or number 2, that is pressure overload, which is because of any obstruction. And how to differentiate both of these? That is because of the time course. If we have acute jugular venous distension, then most likely the cause is pressure overload, and we start looking for obstruction. Then we also see that if we have elevated creatinine and we don't have the baseline, then we assume that it is acute. And if we see that the kidneys, they are small, atrophied, then we can consider that it was chronic kidney disease only, if we don't have the baseline. And then we saw hypoalbuminemia in the labs, and then the differentials came to our mind: nephrotic syndrome, cirrhosis, and vascular leak syndrome. Nephrotic syndrome, there were many evidence to prove that hypoalbuminemia, pitting edema in legs, and we could also see the evidence of hypercoagulability. So we were concerned about nephrotic syndrome. There was no much evidence of cirrhosis. And regarding the vascular leak syndrome, we decided that urinalysis would be the key in deciding it. And then another teaching pearl, we learned that BNP, brain natriuretic peptide, it's elevated because of stretching of atria. So in most of the pericardial diseases, which can cause jugular venous distension, atria is not stretched. Hence, BNP might not be elevated in those cases. So just something to keep in mind. And then we discussed about the various histologic subtypes of nephrotic syndrome. The main ones, membranous nephropathy, FSGS, minimal change disease, and the others being membranoproliferative, IgA, and amyloidosis. Finally, it was realized that the patient is having hypercoagulability and hypertriglyceridemia, and we thought that we have to confirm nephrotic syndrome. So what are the two tests we can go? We can go for serum PLA2R antibody test, which is the only test other than the invasive kidney biopsy to diagnose the nephrotic syndrome. And it points towards the membranous nephropathy. And the other test is the kidney biopsy, as we said. So these tests were done. Anti-PLA2R antibody was found to be positive, and the kidney biopsy showed membranous nephropathy. So the whole case was diagnosed as a consequence of nephrotic syndrome. Thank you so much for teaching. Thank you.
Anmol, that was unbelievable. Absolutely outstanding job with bulleting all the teaching points along the way and narrating this journey so well. Teaching Points has missed you, and I'm glad that you're back in the helm. I was just texting Prof. Rez, Jerome. We were just texting back and forth, actually, about how special this case presentation was. And I think that, the traditional kind of VMRs and CPS cases will tell you that the PE is the easy part and the nephrotic syndrome is the hard, challenging part. But I think for those of us who take care of patients in real life know how hard it is to say that the patient with a white count of 13 with a chest X-ray infiltrate does not have pneumonia. And for you as a busy internal medicine resident with only 1 year of clinical patient care under your experience as an early R2 to sniff out, not just that this wasn't pneumonia, that this was a devastating, almost likely lethal condition that the patient has. So it's not often, I don't use this term lightly, but I think your astute recognition of the syndrome probably saved this patient's life. And I really, really appreciate you. I appreciate people like you who have obviously worked very, very hard to be able to do something like that. But also that you then think to share that message with us. I think many, many people are so much better equipped to do the same when their time comes. And for all people here, I'm sure it will. So really, really grateful for you. I just want to hand the mic to you to close us out today. Any words of advice from reflections on this case or things that you've done? And then we'll bid everyone farewell.
Yeah. Thank you everyone again for the compliments. It was a very, very great case. It was one that I kind of followed retrospectively once I even rotated off service. He's actually doing quite well now. He's still traveling and he actually has good follow-up with his primary care physician, which is awesome. But I think the biggest thing once I did my diagnostic autopsy, like just looking at the case whenever I managed him overnight, was really, I'm thinking about the tempo that you kind of highlighted in your earlier discussion, was to really kind of focus on, yes, it seemed like there was other things that just weren't addressed because he was very forthcoming about not having good follow-up and not being one to go to the routine screening. So thinking that there was a chronic to subacute process, but then there was something that made him come in because he said he was profoundly short of breath and he had more chest discomfort than he ever had. So just thinking about the tempo of symptoms was something that was very, very important for me. And that's something I even stress to the medical students and the early interns now is whenever you're getting your HPI, just make sure you take enough time to really focus on the timeline of the symptoms, and then just trying to get a better hold on the progression of things so that you can make an accurate diagnosis and kind of advance that patient's care. So that's probably my biggest teaching point from this one, just from being like an early resident, is to focus on those things and pay very, very close attention to the tempo of the symptoms.
I hope you come back and teach us many, many more things. It was a pleasure to have you here today. And I think the VMR community will demand more learning from you in the future.
I'll be happy to come back. Absolutely.
Wonderful. Thanks, everyone.
All right. Thank
Bye,
you.
Prof. Rez.